Good morning, everyone. I'm Jeeva Jagannathan, a second year internal medicine resident from St. Vincent Hospital, Worcester. I bring to you a poster on the tale of two antibodies, a hepatic conundrum, is what I shall call it. You see, since 1800s, the description and study on the autoimmune liver diseases has been very extensive. The autoimmune hepatitis was initially deeply explored, and later the autoimmune spectrum expanded with conditions like primary biliary cirrhosis and primary sclerosing cholangitis. Though most often are individually manifested, these conditions can present simultaneously or sequentially, creating what we describe as an overlap syndrome. Among the autoimmune spectrum of liver diseases, categorization becomes essential from a therapeutic and thus a prognostic standpoint. So, going into the case, we had a 36-year-old Caucasian female who had been an alcoholic for the last 10 years who presented with yellow discoloration of skin. She had an episode of dark stool and easy bruising but denied any hepatotoxic medications, abdominal pain, tick bites, travel, or fever. She neither had a history of jaundice nor any family history of blood disorders. On initial evaluation, vitals were stable and she had an icteric skin and sclera, but otherwise a completely unremarkable physical exam. Labs, as you can see, had an elevated bilirubin and transaminases with elevated alkaline phosphatase indicating cholestasis. A right upper quadrant ultrasound was negative for any gallbladder or biliary pathology. On further evaluation, hepatic viral panel was negative and so was acetaminophen levels, though the serum alcohol level was at 155. A serological workup was instituted which showed positivity for antimitochondrial antibody, anti-smooth muscle antibody, but negative for anti-nuclear antibody and anti-liver kidney antibodies. With this perplexing data, it was unclear whether we are dealing with autoimmune hepatitis as the transaminases were elevated with anti-smooth muscle antibodies, or is it primary biliary cirrhosis as the cholestatic pattern was present with antimitochondrial antibodies. In this situation, a liver biopsy was necessary and it showed portal and periportal infiltration with lymphoplasmacytic cells with ductal proliferation with septal and bridging fibrosis. So, finally, a diagnosis of autoimmune hepatitis and primary biliary cirrhosis overlap syndrome was made. What we learned from this patient was, as we know, autoimmune diseases, which are common in women, has had varied presentations. In this context, autoimmune liver diseases can present in coexisting pattern or sequential pattern stemming from genetic and environmental triggers. Since the clinical features and serological markers are not very specific, a criteria based approach in this context, the Paris criteria has been used, which includes liver transaminases, anti-smooth muscle antibody, and characteristic histological patterns of autoimmune spectrum to arrive at a diagnosis. As you can see from the graph, though underlying inflammation is common to all, the severity and the clinical outcomes depend on the extent of each condition's contribution to the spectrum. The treatments have been based on corticosteroids and ursodeoxycholic acids. Unfortunately, even with intensive and prolonged therapy, the outcomes have been not satisfying so far. The disease pathogenesis and the clinical course varies between individual and overlap presentations, and thus it necessitates specific treatment plans. But to our disadvantage, enough RCTs for treatment are not currently available. Hence, the point to be taken at home today is the need for the extensive research on the understanding of the pathogenesis and further treatment options for the autoimmune spectrum of liver diseases. Thank you for your time and audience.